Afternoon and welcome to OC Talk, the show dedicated to helping home health and hospice providers keep up to date on the documentation, diagnosis coding, OASIS, and HOPE assessment data collection issues that matter most in home health and hospice. I'm Jan Milliman, Director for OC, and I'm happy to be hosting today's program. And now I'd like to introduce our industry guest for this episode. Apologies, my slides are a little out of order. Okay, and now I'd like to introduce our industry guest for today. We have with us OC Advisory Board member Lisa McClammy, and Lisa is going to be speaking with us today about medical necessity at research. Thanks so much for joining us today, Lisa.
Thanks so much, Jan. All right, so we'll just jump right in.
All right, and before we get started, I just want to say if people have questions along the way, go ahead and key them into the chat pane and we will try to get to as many as we can. And now I'll turn it over, and Lisa, just let me know when to advance those slides.
Okay, thank you, Jan. All right, so y'all may be wondering, why are we even talking about medical necessity documentation at research? So recently, auditors are looking at this really judiciously. We're seeing a big increase in denied ADRs, and if you're in a pre-claim review state, we're seeing those non-affirmations, or RCD state and doing pre-claim review, we're seeing those non-affirmations for that reason. So let's talk about what you need to do. First of all, understand the definition. Anytime you're billing Medicare, the services have to be reasonable and medically necessary, and that determination is going to be based on the individual patient's medical condition. The individualized plan of care and other documentation is what's going to determine if the services you're providing are medically necessary. Coverage decisions are based on objective clinical evidence of the individual need for that care. And it's the agency's responsibility to prove that medical necessity and if the care is reasonable. So how are some ways you can do that? Your individualized treatment goals and progress or lack of progress to those goals is a part of it. Describing that patient's medical condition and their functional limitations at the time of research, not what they were 60 days ago, is also part of it. And then hopefully, your patients are improving, and it's up to you to continue to document the current condition and the reason they still need you. And that objective information is what it's going to take to justify that continued care. Next slide, Dan. So a little bit more on the definition. All of this is actually from CGS's website, but Palmetto and NGS both have the same information. You can get it there too. You have to identify the skilled service that you will continue to provide. And like I said on the last slide, you need objective data to support that skill at the point in time that you're doing the assessment. You want to document the complexity of that patient's condition, their comorbidities, and how those comorbidities are affecting the outcomes you're trying to achieve. Generally, that documentation has to show significant changes in the condition, and the plan of care needs to reflect those changes or those ongoing needs. Next slide, Jan. All right, so we're specifically talking about research, but this really is true throughout the care. It really doesn't matter, not just at research time. You have to present a clinically significant, consistent picture of the patient, and they have to remain homebound. So let me give you an example. If you're a therapist, discharges the patient a week before research time, and in their discharge, they document the patient's met all the therapy goals, they're able to walk 150 feet with their walker in the home, then you come in the next week for research and you document that the patient needs assistance of a person to safely ambulate, they need assistance to get to and from the toilet, they're short of breath when walking more than 20 feet and have to sit and rest. Those things don't go together. So either the therapist has the patient much more independent than they really are, or you're trying to justify that they're still skilled and they're still homebound and that they need to stay on your services. We see a lot of situations like this where that documentation isn't consistent, and we're seeing denials based on that. So justifying medical necessity requires that you document the progress to the existing goals, what changes the patients had to their medical condition, have they had a change in caregivers or their living situation or whatever that makes it so that you need to continue to see them. And we're going to talk more in depth about these in the coming slides. Next slide. Okay, so how do you continue to justify skill need? When you're doing wound care, catheter care, IV medications, those types of things, it's a little easier to justify as long as the patient stays homebound. But when you're talking about teaching, that's harder. It's harder to justify that ongoing. If that patient still needs more time and the progress is well documented with whatever barriers there are specific to that patient as to why that teaching wasn't completed in the first 60 days, then you may be fine. What you can't do is say that the patient's 90 or 100% to the goal and just keep it going for not documented change or other reason. So, you know, if you don't have something changing or you don't have some barrier, then you can't just continue to teach on the same things over and over. When it comes to observation and assessment, you want to remember there has to be a reasonable potential for change in condition. And if that's the case, then generally you can go for justify the care to keep going for 3 weeks. So new medications, monitoring for side effects, monitoring their blood pressure, all of those types of things for 3 weeks. Once everything's stable, then you really need to be discharging that patient. You really can't justify it past those 3 weeks. Now, with that being said, also think about if the care is not considered justified, if those fluctuating signs and symptoms are long-standing for that patient and there's not been any changes to the treatment. That's on that last bullet point there. So, you know, if this is normal, this is what happens with that patient and it happens over and over, you can't keep justifying it on that same reason. Remember that this has become a focus in the past few months. So just because you've been able to recert patients in the past, you may start seeing denials for those long-term chronic patients. Next slide, Jan. So let's talk about some key documentation elements that you want to make sure you're including and make sure all of your staff, and that includes both the field clinicians and QA staff, you want to make sure they're aware of these things. You need to make sure you're describing the current, at the time of the assessment, clinical picture of the patient. Do they have a new or exacerbated diagnosis? Has there been a significant change or a deterioration? Also, what's their functional status? This is extremely important for continued homebound, justify therapy, justify the home health aide and nursing. Functional is extremely important. And then also, has their living situation changed? So is there a new caregiver? Is the caregiver managing the wound care? Or, you know, do they need additional teaching? Do they have a home exercise program and they're managing that? If they are, then you may not be able to justify staying in that home. A change in caregiver, though, could help justify that. You know, you may need to do more teaching, more training. Their living situation, they may have gone from their home to an assisted living. You know, there may be some changes that you need to stay in there for, but you just want to make sure that your documentation is very clear as to why you have to go for another 60 days or 3 weeks if it's for the observation and assessment. Make sure it's extremely clear. Next slide, Jan. More key documentation elements, you know, is that progress to goals. You want to make sure that if there are new goals or interventions added at research time, why? Are they based on changes in that condition or new teaching needs, barriers? And if you continue goals, you need clear documentation as to why they didn't learn them in the last cert period or the first cert period, wherever you are in their care. Again, CMS is going to want to know why. Why is it going to take you more time to teach this that you've already been teaching for 60 days? What are some risk factors? You know, emergency department use, hospitalization, obviously. Why did they go? Could it have been prevented? What are their needs based on why they went to the hospital or used the emergency department? Those unstable chronic conditions, just because the condition is chronic doesn't mean the patient doesn't have acute exacerbations. We know that, but you have to document those really well. Recent falls or increased risk for falls, the patient's falling, this can help justify the care, but what specifically are you going to do about it? You can't keep going without clear goals and showing progress to those goals. A decline in their ADLs or mobility or the cognitive function, either one, we know our patients, are going to decline potentially, either physically or cognitively. But if you're continuing to go and see that patient for one of those reasons, you need a plan. You can't just keep going because they're getting more confused or more forgetful or need the aid to help them with their bathing and dressing. You definitely need to have a long-term plan on what you're going to do, even in the face of that decline. All right, next slide, Jan. So when you're talking about documentation gaps and no-nos, we see this all the time. You don't want to copy and paste from one assessment to another, or from one note to another for that matter. So many times we will see the same exact assessment narrative at Recert that was written at Start of Care or at the previous Recert. Hopefully there's been some changes. If not, you're probably not doing your job. So you want to make sure that if you allow that copy and paste, that your clinicians know they have to update it. It's just blatant whenever you have no changes to that copy and paste forward. The assessment findings a lot of times will be from a template or AI generated, and you can absolutely tell that when you're reviewing charts. Every patient looks pretty much the same with just slight tweaks in it. The homebound, the functional looks very, very much the same from one patient to another. You absolutely don't want to be doing that either. We already talked about interventions and goals being carried forward and the continued teaching with no new knowledge deficits. If you do this, you want to make sure when you carry those goals or interventions forward, describe in detail the specific barriers that prevented you from meeting each individual one of those goals or interventions, or completing those interventions in the last 60 days, and why you have to continue. Sometimes we'll also see an agency add a new discipline without any justification. So it may be 100% appropriate if the patient had PT and now you're putting OT in. Just make sure you describe why. Maybe that patient couldn't handle doing both therapy disciplines at one time, and you needed to complete the physical therapy before you brought OT in, or something like that. Whatever it is, make sure that you're describing that. Don't just say, oh, we're going to restart them, let's put OT in this time. Why are you doing that, and why did you not put them in the previous cert period? When you're talking about homebound, so functional status answered in the OASIS, when you're talking about the M1800s and the GG0130s and 0170s, if that doesn't match the clinical narrative and homebound documentation, here's an example. We see where the patient's able to walk 50 feet with 2 turns or 150 feet with their walker and standby assistance. That's how you're documenting it in the OASIS. But the homebound narrative says the patient has to sit and rest when ambulating more than 20 feet due to shortness of breath. Those two things don't go together. They don't match. Because to answer the GG questions for the walk 50 feet with 2 turns and walk 150 feet, they can't take a sitting rest break for those questions. So remember that if you document your homebound with they have to sit after 20 feet, but then you're saying they can walk 150 feet. Those two things don't go together. I already mentioned this one, but when therapy goals are met, discipline discharge, conflicts with the nursing documentation, you have to be careful about that too. You want to make sure that it looks like the same patient. Another thing is when it comes time for research, sometimes the coding's adjusted, and it should be if that initial primary diagnosis is resolved or it's not the focus anymore. And that's fine as long as the clinical picture, the documentation of the clinical picture matches. if all the documentation, again, needs to look like the same patient. So make sure that if you're updating that coding to the primary diagnosis to something else, that that's what your focus of care is in your clinical documentation too. Okay, so now let's look at some examples. Next slide, Jan. So these come directly from the Medicare Benefit Policy Manual, and I thought they were pretty good examples for us to go over in this webinar. The presence of a plaster cast on an extremity generally doesn't indicate the need for skilled nursing care. However, the patient with a pre-existing peripheral vascular or circulatory condition might need skilled nursing care to observe for complications, monitor medication administration for pain control, and teach proper skin care to preserve skin integrity and prevent breakdown. The documentation must support the severity of the circulatory condition that requires that skilled care. The clinical notes for each home visit should document the patient's skin and circulatory examination, as well as the patient and/or caregiver application of the education principles taught since the last visit. The plan for the next visit needs to describe the skilled services continuing to be required. So that's very complex, and it's going to take a lot of documentation to justify that, but that would be justified. In every one of these examples, and I'll mention it again at the end, each one of these say the clinical notes for each home visit should document whatever. So you have to make sure that, you know, this would be an unusual situation that would be medically necessary for skilled nursing, but you have to make sure that documentation ongoing in each note documents everything to support that skilled need ongoing. Because once you get past the skilled need part, once you get everything taught, you know, the skin documented or that plaster cast comes off or whatever the situation is, then you're going to discharge that patient, you know, unless there's another skilled need. All right, next slide, Jan. So a patient with a well-established colostomy, absent complications, so there's no complications, may require assistance changing the colostomy bag because they can't do it themselves and there's no one else to change the bag. So notwithstanding the need for routine colostomy care, changing the colostomy bag doesn't become a skilled nursing service even when the nurse provides it. So just remember, just because they don't have somebody that can do it doesn't mean it's okay for you to go in there. This would not be medically necessary, and it would be denied if there were no complications that you needed to be in there for. All right, next slide, Jan. A patient was hospitalized following a heart attack. Following treatment, he was discharged home. Because it's not known whether increasing exertion is going to exacerbate the heart disease, skilled observation is reasonable and necessary as mobilization is initiated in the patient's home. The patient's necessity for skilled observation must be documented at each home health visit until the patient's clinical condition and/or treatment regimen has stabilized. So this is one of those that would probably be for about 3 weeks unless the patient had some instability there. And then at that point, you could extend that depending on, you know, each patient's individual progress. But because of the new heart attack or the recent heart attack and the fact that we wouldn't know how the increase in activity is going to affect the patient, then this would be considered reasonable and necessary as long as, you know, you're documenting at each home visit until they're stable. All right, next one, Jan. Patient with hypertension suffered dizziness and weakness. The physician found that the blood pressure was too low, discontinued the hypertension medication. Skilled observation and monitoring of the patient's blood pressure and medication regimen is required until the blood pressure remains stable and in a safe range. The patient's necessity for skilled observation must be documented at each home visit until the patient's clinical condition and/or treatment regimen has stabilized. So again, it's got to be documented ongoing. This would be another one of those that would be for about 3 weeks. You could be justified unless they have some instability, and then you could extend that potentially. But you've got to make sure you're documenting this really well at every visit, why you have to keep continuing. All right, Let's go to the last example. Physician has ordered skilled nursing visits to teach self-administration of insulin to a patient who's been self-injecting insulin for 10 years because the patient recently lost the use of their dominant hand and has to be retrained to use the other hand. Skilled nursing visits to reteach self-administration of the insulin would be reasonable and necessary. The patient's response to teaching must be documented at each home health visit until the patient has learned how to self-administer. So this is the perfect example of that significant change in condition. That patient was able to self-inject for a really long time, but they lost the use of that dominant hand and had to be retaught. So again, like I said earlier, one thing that you want to be sure and remember is every single home health visit has to document that ongoing need for that skill. And once, you know, whatever the goal is, the teaching is done or whatever it is, or teaching them to re-inject their insulin, whatever the situation is individual to that patient, once that's done, then you should be discharging that patient if there's not another skilled need to keep you in the home. I hope this helps you when you're taking a fresh look, because you need to be looking at every research and thinking about medical necessity and homebound, because you may not have noticed any changes yet. If you're not in an RCD state, you may not have, but if you start getting ADRs and they start looking at your research, you may have some issues. So you want to make sure you're taking a fresh look at all of your research and make sure that they're still medically necessary, that you're beefing up your documentation, and that your daily or your weekly or every other week, whatever your regular visit notes, you want to make sure that you are justifying that medical necessity on every single note. All right, I went through that relatively quick, so Jan's got some follow-up to do, so I'll hand it back to her.
Fantastic. Thank you so much, Lisa. There was so much good information in there. And running through those scenarios, I think really shows the types of situations where that documentation obviously is essential to, you know, support that care. So thanks so much for sharing this with us.
Absolutely.
And now it's time for our scenario spotlight. We have a new scenario this month centered around answering M1033 for history of falls. So we're going to share that scenario with you today, and then you can think about what the correct answer, what the correct response would be, and then we'll share the answer to this scenario next month. Lisa, do you want to read through that scenario?
Absolutely, I'd be happy to. Okay, so when you're talking about M1033, the first one, hospitalization risk, history of falls, at the start of care visit on January 5th, 2026, and pay attention to the date there, you notice that the patient has a large bruise to the right arm. The patient reports that yesterday her granddaughter was playing with the dog and accidentally ran into the patient, causing her to lose her balance and hit the edge of the kitchen cabinet with her right forearm, resulting in bruising and some pain. Which response would be true regarding M1033.1 history of falls for this patient? A, do not check because the patient has only had one fall. B, do not check because an overwhelming external force is not considered a fall. C is check because an overwhelming external force is considered a fall. And then D is do not check because an intercepted fall is not considered a fall. So you got to decide which one's true of those.
Great. Thanks so much, Lisa. All right. And next up, we're going to move on to, oh, well, just to let folks know, remind you again, we will be sharing the answer to that at our next call in January. And next up, we have the product spotlight. This month, we're highlighting AHCC certification exam study guides, and you can get fully prepared for your AHCC certification exam with our comprehensive study guides. Each guide covers key topics for an AHCC exam, as well as practice questions and insider tips to boost your knowledge and reduce test day stress. It's your ultimate tool for HCS-D, HCS-H, or HCS-O exam day success. Plus, AHCC members can receive a 20% discount on any of the study guides at checkout. So follow the link in your handouts to order your guide today. And if you're listening to a podcast version of this call, you'll find the handouts on the OC website under Resources, Free Webinars. And now it's time for What's New with OC, where we share updates from the Association of Home Care Coding and Compliance. If you are an OC member, be sure to watch the next OC e-zine for an opportunity to register for our next OC member webinar. And our January 28th call will focus on a variety of topics, including recent OASIS updates, COPD coding, and using other specified codes. So be sure to keep an eye out for that registration link so you can join us on January 28th. We hope you enjoyed this episode of OC Talk. Thanks again, Lisa, for all the great information you shared. And thanks to all of you for tuning in. We hope you'll join us again for our January call when OC board members Lisa Selman-Holman and Kelly Kavanaugh will be joining us to discuss recent changes around documenting falls in home health. And in the meantime, if you'd like to re-listen to this episode or a previous one on the go, you can find OC Talk on your favorite podcast app, or you can also listen to the recording and access the handouts on the OC website at oc.decisionhealth.com. And if you have any suggestions for future guests, topics, or ideas about the format of this show, please send me an email at jan.milliman@decisionhealth.com. Thanks so much for listening. We here at OC wish you all the best this holiday season, and we'll see you in the new year. Take care, everyone.